evening, everybody, and welcome all of you to the live program number 161 at Orthopedic Principles. Today, our guest of honor is distinguished faculty, Professor Deiary from the United Kingdom. Professor Kader is an accomplished knee surgeon, researcher, academic, educationalist, humanitarian, and previously a specialist surgeon for the International Committee for the Red Cross. After completing his orthopedic training in Scotland and knee fellowship in Sydney, Australia, and Newcastle in 2005, he was invited to accept the consultant trauma and orthopedic surgeon post in the Queen Elizabeth Hospital NHS Trust in Gateshead, and also to become a team doctor for the Newcastle United Football Club. He's been a consultant orthopedic surgeon with special interest in complex knee surgery at the Southwest London Elective Orthopedic Centre in Epsom since 2015. He's also the visiting professor in the Faculty of Health and Life Sciences at Northumbria University. Today, it's my great honor to bring back Professor Deiary for this wonderful live program. Over to you, Prof.
Thank you very much, Hitesh. Can you hear me well?
Yes, please.
Excellent. So as Hitesh said, I work with many organizations, but my base is in Swallyoak in London, and I'm also affiliated to multiple other universities and research bodies. Today's talk is all about meniscus. I just wanted to make it clear that not every photo or diagram is my own one. All the videos are mine, and many anatomical pictures are also mine. It's all my own dissection, but there are a lot of diagrams and drawing from my colleagues or from the internet. We teach most of this stuff at a cadaveric course yearly in Watford, which is Smith & Nephew Lab. It's called the London Advanced Knee Arthroscopy course, which is run by BOSTA, which I am the vice president of. It is all hand-on for 2 days operating on cadaver. We also aim to do courses internationally. We've done one in Baghdad last year and another one in Kurdistan, where I come from. We are aiming to continue that theme of teaching. And if anybody wants to come to Kurdistan for our arthroscopy course, we usually get a fantastic faculty, and it is safe. Now, going back to the talk, I'm going to cover 5 main topics around the meniscus. So the body of the meniscus, the root of the meniscus, ramp lesion, zip lesion, and also there are some lesions in the periphery that need to be addressed. Many years ago, 100 years ago or more, the meniscus was thought to be a functionless remnant of intra-articular muscles. Not until Fairbank pointed out that meniscus is an important part of the knee, and losing the meniscus may lead to a degeneration and joint line narrowing. The meniscus is mainly type 1 collagen. It's full of water and some organic matter. The collagen constitutes about 75% of it. If you look at the medial and the lateral meniscus, there is a huge difference between them. So the medial meniscus is crescent shaped. It's thicker posteriorly. The posterior horn is about 20 to 25% thicker than the anterior horn. The lateral meniscus is round, and its roots attached very closely to each other. The lateral meniscus is very, very important because it is serving hugely in the congruity of the lateral compartment, which is convex on convex surfaces. These are my own dissection. I'm trying to show you the medial collateral ligament, the superficial part of it, and the oblique ligament. And if you remove it, you can see deep MCL and how it is closely blended to the medial meniscus. And this is the semi-membranosus, and it has multiple arms, and some of it inserts around the meniscus. And then I think in here, where you see the meniscus is wedged. The meniscal fibers are arranged in such a way that it contributes massively to its function. So the superficial network is a bit random, but deep you would have longitudinal fibers or circumferential fibers. These fibers are tied by some radial fibers. They play a major role in resisting hoop stress. So the pressures or the load, the axial load will get converted to a transverse load or radial one, and then the longitudinal fibers contain that load and hoop stresses. The blood supply is mainly from the genicular arteries, but as you know, only the outer border of the meniscus is vascular. So in the medial side, 20 to 30% of it's vascular, called the red zone, and the lateral side, 10 to 25%. Of course, that's different in children. The rest of the meniscus get its nourishment from diffusion and mechanical pumping. Joint motion is essential in the nutrition of the meniscus. And also the meniscus is important for the chondral nutrition. So the main functions of the menisci are is a load transmission, especially in flexion. And as I said, the lateral plays a major role comparing to the medial side. They play a role in joint stability, congruity, lubrication, proprioception, and also they increase the contact area and they reduce the point loading. I had the pleasure of visiting Brian Cole, who is one of the top knee surgeons in the world. I'm going to probably mention a few others who have massively contributed to my education and everybody else's. So Brian has probably delegated this work to one of his juniors, Dr. Lee. Has produced this data related to the decrease in the medial contact area and the increase in the peak stress. So if you excise 50% of the meniscus, the peak stress increases by 43%, while if you remove the whole meniscus, the peak stress increases by 135%. The meniscus contributes to stability of the knee. So therefore, when you have an ACL deficient knee plus meniscal injury, then you would have more instability in that knee. Unfortunately, those menisci, especially when you get older, they get torn easily. When you're younger, these menisci require a significant amount of force to get torn. The tear configuration plays a role in our clinical management. So as you know, there are vertical ones, radial ones, flap tears, and we're going to go through this by various images and MRI scans. So these are the various tears, and some people classify this as grades. The early grade, the 1 and 2, is just mucoid degeneration. They are not part of meniscal tear. Some tears are better left alone. I mean, here it says small ones to 8 millimeter up to a centimeter, even centimeter and a half. And if it is partial, you better leave it, especially if you have a tear in the posterior horn of the lateral meniscus in association with ACL tears. Those tears heal very well without intervention. MRI scan plays a massive role in our understanding of the configuration of tears. There are different types, of course. Here you can see some vertical ones, some oblique ones. And then I would urge you to look at the axial views. You can see some big, massive radial tear in this view. There are also complex tears that are very, very difficult to manage and especially hard to repair. You can see these type of tears, which are common, especially in younger people. So these are bucket handle tears. And again, here in these MRI views, you can see the double PCL sign and double delta sign. That is the fold in the anterior part of the meniscus. Please be aware there are certain MRI signals, especially in younger people. They are not, this is not a tear, this is just high vascularity in the meniscus in a younger person. Again, this is just transverse ligament, it's not a tear. Now, patient with meniscal tear, you probably know this, these are the basics of understanding knees. It's usually an acute event if it is a traumatic one, but it can be just a minor thing such as getting out of a car. Then they develop swelling, which is not immediate like ACL, effusion, the same thing. Then they would have catching, locking, and some people would report swelling after exercise. This is the body of the meniscus. However, if you have a root tear, then it is really much more subtle than the body tear. So usually they complain of posterior knee pain and pain in deep flexion. And then the pain is much more severe than body pain. Some of them recall a minor incident that happened, but there's no locking or catching symptoms. And that's why you have to keep a high index of suspicion to diagnose root tear. Of course, the root tear cannot be diagnosed by just joint line tenderness. Many of them probably don't have that. So this is very important for body tear. The management of meniscal tear is generally very much dependent whether it is traumatic or degenerative tear. If it's a traumatic tear, it's good to attend to it early. While when it is degenerate, you better probably give it 3 to 4 months before you attend to, unless there are some mechanical blockage, and some of the degenerative tears cause lots of symptoms even after 3 to 4 months, that then you will need to intervene. Your intervention can vary from excising the meniscus, which is becoming less favorable nowadays. Many years ago, probably 90% of the menisci were getting excised, but nowadays, it is probably half of it getting excised and half repaired. That is probably in only the advanced countries. And then preferably you repair all sorts of menisci. Today, if I manage one thing, hopefully I will encourage you to repair certain type of menisci that we didn't have the courage to repair many years ago. And then there is meniscal transplant, and there is meniscal replacement. So essentially, if you have a tear which is in the red zone, it's better to repair. If you have a tear in the periphery of the meniscus, and that is, sorry, in the central part of the meniscus where the blood supply is poor, then you have to think about excising that. Now, if you excise the medial meniscus, there will be some radiological changes probably around 20 to 25 years later. However, if you excise the lateral meniscus, 10 to 12 years later, there will be some radiological changes. Of course, it's better to do a partial excision. And there are people who don't do well, such as female and overweight and older patients. So the partial meniscectomy indicated, as I said, in the white zone. And if you have a meniscus that cannot be reduced and it is deformed, then it is better to excise, because meniscus and soft tissue is very much like fracture. You have to reduce it before you fix it. So there are different types of repair or configurations of repair. There are some, you can put some circumferential sutures around them. You can tackle the meniscus, put some sutures from the top, Preferably, you put sutures from the top and the bottom, so to avoid puckering of the meniscus. So the outcome is very much dependent on what type of patient you're dealing with, their age, the chronicity of the menisci that has been injured. Acutely, they respond better to repair. Also, the type of tear and the location, vascularity, the tissue quality. As I said earlier, if you have a chronically torn, deformed meniscus, it's very difficult to make it heal. And then it's very important to repair a meniscus in a stable knee and a knee that is not malaligned. So you have to pay attention to those. This meniscus is just fragmented, and it is possibly best to excise. This one is a bucket handle tear, chronic. You can see how the edges are round, and there is also another radial tear, so it's almost becoming a complex tear. This difficult to reduce, may be suitable for excision. The lateral meniscus, you have to do your best to get the lateral meniscus reduced and repair it. And you can see, because the lateral meniscus, the lateral condyle and the tibial plateau both are convex. Therefore, the meniscus is essential for congruity on the lateral compartment more than the medial. This is just a degenerate tear. Remember, even if you take one leaf of those, the contact pressure probably increases between 40 to 60%, depending how much you take from which part of the meniscus. Therefore, trying to even suture these if possible. With the new devices, this will become easier. There are different ways of repairing a meniscus, and these are the inside out is still the gold standard. Of course, the outside in is easy and cheap. All inside, you have to have certain devices. I'm going to show you most of these devices. They are developing, they are becoming, better at repairing a menisci. These are the different things you could achieve with inside out. And of course, with all inside. So this is, I'm taking you through the inside out technique. You need these long needles, and you need zone specific cannula, maybe a spoon or certain other specific devices. But essentially, you can do most of the meniscus safely, but you need an extra incision to do the back of the meniscus. Therefore, many people will find it, just an extra hassle of an incision, so trying to use all inside. The sharpshooter is useful, especially when you do meniscal allograft transplantation, because it helps you to put multiple needles at a higher speed. The outside in is a very interesting concept, and it's very cheap. As I said, you don't need specialized needle for this. You just need 2 needles and a monofilament suture or PDS. So you can use it to fix menisci with 2 stab incisions. You can see you put 1 needle in, one of them will have a loop, the other one will have a suture, and then you pass that suture through the loop. So, there are these devices, but you can just use a suture as a loop, and all very cheap, and then tie the meniscus peripherally. You can even suture radial tears with these very effectively. So the all inside repair, you have multiple devices. I've used all of them, probably not the cross fix, but I've used the other 4, and they're all effective. They're all equally strong. I think it is what is available to you and what your hand is used to. I use FastFix 360 because I find it easy to use and I'm used to it, but I'm sure the rest will do similar thing. So the these are the FastFix 360. This is how it works. You have a cannula, you have a curved needles, and preferably you put vertical mattresses if possible. Sometimes it is not easy with all inside. And then you can tighten it. There is a knot pusher and also cutter at the same time. So that's how that works. That's a YouTube video, so you can watch it at any time. Again, this is called Nova Stitch, and no. Can you hear me still? Sorry.
Yes, please.
Okay. So this Novo Stitch is, we are hoping to get it next week in our department, because this has been out for a few months, maybe even a couple of years, I don't know, but it seems like it's very easy to use, and it can pass some circumferential sutures. And when that happens, it's very useful to treat horizontal tears. Yeah. So this is the OmniSpan from Mytech. Again, it is a useful device. And this is a meniscal cinch from Arthrex. Does the same thing. Some surgeons really like this one. And then I've used this one. You can put with a sequin, you can from Lymphatech, you can put multiple sutures at the same time. They've been all tested. This is not exactly a new paper, but these have been tested before, and they have pretty much same load to failure on cyclical loading. The vascularity of the repair is very, very important, and repairs are more successful when you do them with ACL because of the tunnel drilling and the amount of bone marrow, which can help as a cell-based therapy, so to speak. So remember one thing, for all inside, you don't have to just use those devices. I have been using the Scorpion, preferably I've been using the First Pass Mini, not the standard one. The Mini one is for knees, and it's low profile, and you can put as many sutures or tapes, and it works out cheaper overall. To optimize your healing, you need to do a few things. I always do the notch microfracture to get some bleeding. Of course, you have to rasp the lesion, both sides, and even trephine them with a needle, both sides, so that you produce some bleeding channels. There are people who are very keen on using a fibrin clot, and you know, it's a good idea, but it isn't easy to keep it there unless you are you know, technically good. It will be very hard for you to keep those things in, but you know, even at least the rasping, the trephining, and the notch microfracture, these are easy things to do. Now, what would you do with a degenerative meniscus? There are a lot of papers, even some sham surgery has gone on to show that arthroscopy is useless for degenerative meniscus. I don't think that's entirely true. Although I wait for 3 to 4 months, as I said earlier, on these patients before I proceed. But there are times a degenerative meniscus with a flap would benefit massively from arthroscopy, and I have multiple evidence, well, in clinical practice for that. I have tried the meniscal substitutes many years ago. I just unfortunately didn't think much of it. They are either collagen or synthetics or polyurethane. They act as a synthetic scaffold for the meniscus to regrow. That's theoretical. I don't know how chondroprotective they are, and it's a faff to put them in. I know some people promote them, but I didn't think they were useful. These are papers who are showing some good results from these, but that in cadaver. after sheep cadaver, of course, they put them in there and then they tested them subsequently. Now, what would you do if you have a 18-year-old who's lost the meniscus completely? So I think the main option we have is to use either the meniscal prosthesis, which hasn't taken off, or preferably use meniscal allograft. And the meniscal allograft, many years ago, I spent a week in Chicago learning about this, and probably about $10,000 with it, trying to go to this course, how to do these things. But in clinical practice, the cases were not that many for me to maintain that skills. We have some surgeons who do them. And the truth is that there are probably 10 or so surgeons do them around the world. I don't think they are in thousands. And they are the same people who are publishing most on this. And Brian Cole is one of them. When I visited him 6-7 years ago, he had at that time about 200 cases. Probably now he is up to 1,000 cases, and they do them well, and they have good results. Of course, it's generally offered to people who are symptomatic and they have a neutral alignment. Their body weight has to be reasonable, and there shouldn't be arthritis. It's not currently done as a prophylactic procedure, but that is evolving. Maybe at some stage it will be offered in that way. These are good results. These are the main group of people who publish on this regard, including, of course, our own Tim Spalding, who has published lots of papers on meniscal allograft, and he has a vast experience. So it is a reasonable procedure if you address comorbidities and look out for malalignment or ligamentous problem. As I said, there are a few people involved in this business, and it is difficult to know the success have come from just one procedure or the combined procedures. The survival of meniscal allograft is 50% at 10 years. Now, this is very important. If you learn nothing today, just pay attention to these few slides, and that will be the main message. Meniscal root tears are really, really important, because if you deroot the meniscus, then the whole meniscus becomes dysfunctional. Therefore, it is absolutely essential that we look for the meniscal root tear. And I give you multiple examples of people who have been seeing lots of practitioners, surgeons, even knee surgeons, and have been complaining of posterior knee pain. There's nothing can be seen everywhere because the MRI never reported a root tear. And they come to me and I tell them you have a root tear. They get completely surprised by that fact. So it's essential that you look for it. And there are two main groups. One of them is younger adults, like the buddy, and the other one is the middle-aged person who had a minor injury. Some of them remember it. That little thing happened, twisted injury, female mainly, overweight, and they usually have some degeneration. This has been classified, and Dr. Laprade have called it silent epidemics, which is absolutely correct. I mean, there are many of them, and because we don't know and we don't have the knowledge, so we don't look for it. We see what we know. So this is always missed. And you can see look at those old scans. These are my patients. So you can see, some of them just show a minor ghost sign where the black suddenly become gray. Some of them show a significant interruption, which is clear. Some of them show that a bone avulsion. And then in the radial, you can see that one clearly. In the sagittal, you can see a ghost sign again, where, the meniscus is black, 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 and suddenly changes to a gray color. So these different ways of them presenting, and most of the time this is missed. This is the slide you need to remember. Forget the rest of the talk. And every time you see a meniscal extrusion, think meniscal root. Of course, it is not the only cause of extrusion. I mean, arthritis can lead to extrusion. Right? Degenerate meniscus can cause extrusion. Some instability in the knee can lead to such thing. But the major thing you have to remember, look at the root, and then when you see the root, there is a damage to the chondral surface, and that is because the whole meniscus is dysfunctional. So this is the extrusion. Look for it, right? Anything more than 3 millimeter is not benign. So it is essential that you check these things and make sure that there is no complex tear in the meniscus or severe degeneration. Of course, the main one is the root problem. Sorry, just let me move. And here it is very important. So this is the condyle have failed after meniscal root avulsion. And you can see the meniscus is extruded. And when you see zonk, right, when you see what we always diagnose as spontaneous osteonecrosis of the femur, think meniscal root. So this is a paper showing that meniscal root avulsion is very common. 80% of them had that. So if you see osteonecrosis, please think meniscal root avulsion. Now, meniscal root doesn't happen always in the back of the knee. It can happen with the anterior. This is a patient of mine who has anterior root avulsion of the lateral meniscus. We are just writing this up as an addition to a Myron-McKeever classification. This is an ACL rupture with it. So there's an ACL rupture and anterior horn lateral meniscal avulsion. So how do you treat these? You can treat them with these jigs, and you need just an additional jigs for it. With the ACL jig, you need a low profile tibial jig to get to the back of the knee. I'll show you some videos in a second. You need a tape because the sutures are generally cheeses through the meniscus, so the tapes are more meniscal friendly. And you need a first pass mini or a scorpion of some kind. And then you need a special jig to get to the back of the knee. You can use the ACL jig, but you need something lower profile, such as the specially designed for meniscal root. And here are some videos. This is being taught at our cadaveric course in January. So this is my I have recorded this just to teach everyone what to do with the cadavers. So essentially, in the first image, we're trying to create a root tear. And then you can see we have to make sure this is mobile before we fix it. And then otherwise, it is not possible to fix it. And then you have to clean the base, the root, make sure that it is bone exposed. And then you go to the next stage where you drill through that spot. It's always more central than you think, the footprint of the root. And then you can see you have to use the either first pass mini, which is in here, making sure the needle moves away from the cartilage. And then you put 2 tapes on, and these tapes, I'm just going to make them all work because in the interest of time, I think I want to make sure I finish my talk. So there is the tapes, that is, and then you go to you put 2 tapes through, and then you tie them on a button on the tibia. So this is, of course, cadaver. The quality of tissue is not as good. You can see tension. Now, final topic is the ramp lesion. This is being described by Michael Strobel. Michael is an excellent surgeon. I have also seen him operate. He dedicates a lot of his time to taking pictures intraoperatively for educational purpose. And he's published this book, and he described RAM lesion in '88, and we are still struggling with it. It is embarrassing. So if you remember, I've mentioned a deep MCL, and I wanted just to show you how the meniscus is wedged there and where is the ramp. So here is the ramp. So you have the ramp is essentially the capsular attachment to the meniscus. The capsule attaches to the lower 2/3 of the posterior meniscus. So it leaves a recess here, like there will be sometimes fluids in here. And in the bottom, there is a capsule, and then there is a meniscotibial ligament, which is a thickening of the capsule, and it isn't going all around. It covers some part of it. If you see this is the meniscotibial attachment, and it covers some. This is from Dr. Laprade. So there is what it is, right? So it doesn't cover everything. It just covers some part of it. So when you're repairing this, you have to just remember sometimes they are not as strong, the tissue, when you go more medium. This is classified by my good friend Bertrand Sandré-Cote, and Bertrand has redescribed this. This paper was written a few years ago, and he talked about hidden lesion. Yes, it can hide these lesions, and you need to find them. And in the MRI scan, you can see there is a detachment of the coronary ligaments from the meniscus. They are all very, very subtle. And here are more images showing such thing. And here I wanted to show you how to get to the back of the knee yeah. So this is you're looking at the medial meniscus, you pull it, it comes forward like in this image. You know there is something wrong, and then you have to go to the back of the knee and then turn your scope and you see that area. Sometimes you have to shave that area to see the lesion behind it, and that's what Dr. Sandré-Cote was describing as a hidden lesion. Now, this is very interesting. This gentleman, right, he has described this, God knows, when was it? It was essentially 1935. So many, many years ago, he described this sign where the when you do anterior drawer, you can see the meniscus flips forward. Jump sign, he's called it, right? So these are not new, but I don't know why we are so slow to take these things up. So this is one of my patients, again, in the back. I'm just trying to clean, identify where it was. Before that, there was a lesion in there I had to clean, like a big, blob of tissue, which was had to be, so you need to make sure the margins are clean so you can see the lesion. And again, this is a cadaveric demonstration, so we create the lesion first. But this one is interesting, where you can see that there is that was the lesion I was telling you about, so it had to be removed. This is a hidden lesion. So hidden lesion is, again, you pull the meniscus, you use a needle, and you find under the synovium a big lesion. And this was described by Dr. Sandré-Cote and his team. My first one of those many years ago was done. Bertrand visited me to our hospital, and I did my first few. In fact, we had 4 ACL, 2 of them had this lesion. So maybe it was a lucky day for me to practice. And then you can see here how to get to the back of the knee with a needle. And this portal, posteromedial portal, is important. And this was the lesion. We need to remove, clean this, so you have 2 clear edges. And then you use the curved suture hook, lasso. I use the 25 or maximum 45. I can't use the others. They are very hard to work with. And these are just how you put the sutures in. I've also devised another way. You can use the scorpion to the back of the knee, like First Pass Mini. And again, you can play with that and again, tighten that. Now, I need to move on, I think. And this is the scorpion I'm using for this purpose. So it does work. Just you have to be safe and move the needle away from the condylar surface. All these are getting taught at the course. And this is my note. I've looked at all the other notes, I've analyzed them, and this is called Orange Note because we did it at Smith and Nephew lab, right? And it's very, very strong. We've tested it, not biomechanically, but by analyzing the different nodes that are available. And the final two things, which are only 3-4 slides, is the zip sign. So the meniscofemoral ligament, it can be very, very strong, and sometimes it gets torn and unzips the back of the meniscus completely. And I show you, this is one of my patients. You can see that the meniscus has been torn from the periphery, and that is because of the meniscofemoral ligament. Therefore, this is called zip tear because it unzips the meniscus peripherally. And the final bit is sometimes you have a tear in the periphery with a cyst. So you remove the cyst and there is still a tear, but the tear is not going to the intra-articular. So you have to suture that tear in the periphery when you are excising the cyst openly, instead of going from inside and cutting the meniscus. This is another meniscal preserving way. I wanted to point out that we are running a full day virtual research course on 4th of September, and it has a fantastic faculty. I've managed to get 25 people to contribute, all researchers, all highly published. Some of them are the best publishers in the world. And in fact, quite a few of them are like that. And that is on the 4th. We already have 140, but we can take, up to 200 easily. And if you want, you can be part of this by going there. And finally, Paul Vanaskovich and I have these courses next year. One of them is in Jordan, the other one in Newcastle. And thank you very much, Hitesh. I hope everyone enjoyed this, and I'm happy to answer any questions.
Thank you, Deiary. Fantastic presentation as usual. You have looked into the entire spectrum of meniscal injuries. A few questions. Now,
Ready.
You mentioned about a notch microfracture, right? So
yeah.
That is to enhance the meniscal healing. So You're going to microfracture something that is intact, right?
Yeah. So you just put your, it's a bone owl, or it's called like a microfracture owl. Yeah, you just put it into, normally you can put it just anterior to the ACL origin. And then you tap, make few holes and they bleed. I think I've shown a slide where there is some bleeding come out. So just
on the
find
tibial side? Tibial side or the femoral side?
Femoral side. Femoral side.
Notch.
In the notch, you find the notch, and then areas which are not articular, extra, like, there's not covered by cartilage, it is just covered by, synovium and areolar tissue. So you can make a hole in there, 2 or 3.
And do you think of, so you mentioned about cell augmentations. Do you think about any other role for any kind of cell, for example, BMAC or something that's going to augment a meniscal repair?
I have, well, I forgot about that actually. I haven't used those for that particular purpose, but I have used, cell-based therapy for chondral damage, not for meniscus. I haven't done it for meniscus. I don't know what are, I haven't even considered it, because meniscal, I think, of course, some people think, the biology is probably more important even than the technique, but I think it is, the technique is very, very important. I've worked with people when I was training, they put one suture through and they leave it. And I don't know what happened. Probably all of them got ruptured later, but you have to put a few sutures in. It has to be about 5 millimeters, 6 millimeters apart. They have to work. You don't you use one and you get tired if it doesn't work. So you leave, so you have to make it work. And sometimes it's not possible. I had a problem the other day. Whatever I did was going wrong. And that's because I was being too ambitious dealing with meniscal tissue that are poor quality. So I think the technique is very important, and also the additional things you do, but I haven't gone to cell-based therapy for such thing.
And Jari, I have heard a lot of surgeons talk about laser and radio frequency, etc., for meniscal healing. Do you think that's going to be of any benefit?
No, I really don't believe in those things. I think they are hocus pocus stuff, you know. Nah, I mean, since when? I mean, it is.
Now,
They are
ever
all
since
different things.
orthobiologics came in, the people have thought too much beyond.
Yeah, well, that's why you and I, we started with orthobiologics, my first talk, to trying to put all these, you know, myths aside and deal with some real science. I think people who are incompetent to a certain extent, they can't do anything else. Sorry to say this, then they will end up doing just one thing. And I think we have to be, you know, looking at the data. There are no data to support such thing at this stage.
Thank you for that, Jari. The other concern is, have you encountered discoid meniscus in a young patient, and you have a concern with the detachment in the posterior root, the ligament of Humphrey and...
Yes, I know what you mean. Yeah. So luckily I haven't encountered root detachment with it, but I have had probably about, you know, under 10 patients who've had discoid meniscus. And what I have done with them, you know, I've assessed, as you say, you're absolutely right, that it could be unstable. That's why it is causing problem. But then most of the time it is, you know, you do something if there is a tear in them, because there are some of them who, you know, who are completely silent and benign and not causing symptoms. So there's no point, you know, saucerizing every single one of them. So there are some I made the decision to saucerize and remove. And it's very, very difficult one, because you don't know where to stop. So it is a difficult thing to deal with, but the message is not to excise every single one of them, because some of them, you know, they serve a physiological purpose.
And Jari, I remember having read about this particular manual called as Gilchrist manual to really approach a ramp or a posteromedial part of the knee, or the posterior most part of the knee. And
Yeah.
have you had an experience in this particular manual, or how do you really make it to that particular area?
You mean, okay, so there are a few things. So in order to make it to the back of the knee, so first you have to do that maneuver I described. So you have to go through the notch and you turn your scope, you know, to about, you know, in one side is 9 o'clock and another is 3 o'clock. And then if the knee is tight, then for reaching the back of the knee, especially with roots, you can do a pepper pot, or, you know, the pie crusting of the MCL it will give you another 3-4 millimeters if you're lucky. Sometime, you know, if you do them the right way, so you have to do them, I do them slightly distal, as I've described in the anatomy, and you put needle through it and it just gives suddenly, so you get a bit more access. The posterior of the knee, it is when you go in, then I think most of the time you see better if you are flexed at 90 degrees. And then of course with I don't use a pump, but I use a flush, arthro flush. So you can see the back very well, because then, you know, at 90 degrees, everything is pushed posteriorly, like when you do PCL reconstruction, and then you have a better view. So I just do these. I don't do anything, and I get a view, but they are not, you know, it's not easy because it's very tight space and you're trying to put all these sutures, retrieve them, and then, you know, it requires experience, this business. But I think if your listeners want to do one thing, is root tear. Root tear is not difficult to do. It will save the meniscus, and it's very common. It needs to be just, somebody needs to look for it.
And like Dr. Laprat said, it could be a silent epidemic, and that's the one that's going to
He's absolutely right. I
osteoarthritis.
think since I've been looking for them, of course, it's been about 10 years that I mean, this has been around for a long time, like the rest of, like everything else. But then it has been in the past 10 years, it just becomes again that people looking for it and dealing with it. And I have been, gradually, just getting into it and looking for it. And it's amazing what you learn when you look at MRIs properly. You learn quite a bit about the ramp lesion, about the root lesion. I've shown most of these lesions in the scan.
Thank you, Deiary, for this. I mean, I think we have no more questions. It has been a fantastic session, Deiary. A lot of spectrum of meniscal injuries, great learning experience for everyone, including me. And I'm sure this lecture is going to benefit thousands of people across the globe. It's lovely listening to you, and thank you once again.
Yeah, no, thank you. Thanks very much.
Thank you very
Have
much.
a good day.
Yeah, bye-bye.